Hey everybody, this is Dr. Maxwell Cooper, co-founder of DaVinci Academy, lead instructor for the DaVinci Courses and DaVinci Cases series, and the host of the DaVinci HOur Podcast. This is the second part of a two-part initial podcast as part of our collaboration with InsideTheBoards, a medical education podcast platform. Again, we will be co-producing a case series called DaVinci Cases, InsideTheBoards Edition. The audio will be on the InsideTheBoards platform, and the video will be on the DaVinci Academy platform. In this second part, Dr. Patrick Beeman and I will walk through a DaVinci case together, featuring concepts from the female reproductive pathology. Patrick is the co-founder and CEO of InsideTheBoards and an attending OBGYN, so I'm excited to get his perspective on this DaVinci case.
All right, so what's a DaVinci case? I think the idea for what these are is what we're going to get into now. And, preview our plans with InsideTheBoards and DaVinci Academy in the immediate future is we are going to co-create a set of cases, a sort of curriculum for pathology content and ethics content that we'll be collaborating on together. So this is going to be an example of the pathology case. We have never talked, or we've never recorded content before. So that we're just kind of like trying to figure out what the flow will work like here. And so if you have any suggestions, feedback, criticisms, whatevs, just, DM us on social or email us. You can email us at info@insidetheboards.com or email Max at...
Yeah, you can email us at support@dviacademy.com. That's the best way to send that type of information to us.
Yeah. And I would say, too, if you want to help with either of those projects, ethics or pathology, I can't off the top of my mind think exactly what we could use help with, but it's always nice to be able to interact with med students from my perspective, because now that I'm like private, I don't get to interact with med students like day to day, which has been a loss for my professional satisfaction in life, because I don't know, I get energized by the next generation, I guess I can say now that I'm 37 this month. But all right, so let's get into this. Let's get into our case for today, the inaugural DaVinci ITB case.
Of course. All right, so I'll share my screen here. Just kind of the format again, I think I alluded to this. So we'll have, a USMLE style case with a question, obviously. So we'll go through the case. Patrick and I will go through it. This is a female reproductive pathology case, so Patrick's going to lend me a little bit of his expertise as well as we go through this. We'll summarize the key findings. Then we'll take a minute, kind of go through one of the concepts that's relevant to the question, and then we'll come back and go through the answer choices and tell you why the right answer is right and the wrong answer is wrong. So I'll kick it off here with the first case. So a 32-year-old African-American female, G1P1, presents to the outpatient clinic for chronic pelvic pain and heavier menses for the past 4 months. So I think, with this first opening line, often, that's where you can deduce a lot of information. One, this is a younger woman. She's African-American. Again, like I was saying, these questions things are often put there for a reason. So you want to pay attention to race because there's, certain conditions that can be, that certain races are at higher risk for. So you want to just keep that kind of in the back of your mind as you go through the question. Chronic pelvic pain and heavier menses, as Patrick can tell you, I'm sure from his clinic experience, there's a number of things that can cause that. But I think what's key to, in any of these types of presentations to pay attention to also is the time frame. So this isn't something that just woke her up in the middle of the night and made her come to the ER. It's also not something that's only happened for a few days. Like, so she it's 4 months. She's been dealing with this for a significant amount of time. So kind of a subacute presentation here. So she gets her vitals in the clinic. They're within normal limits. So that's, again, she's not sitting in the emergency room or anything like that. So, she's stable. Physical exam is notable for an enlarged, mobile, non-tender uterus. So again, the exam, especially the gynecological exam, is always important to pay attention to because it can give you a sense of, especially on a uterine exam, if the pathology is particularly affecting the uterus. Patrick, I don't know if you have any commentary on that. I'd be curious what your thoughts are.
I do. Definitely, I've got some things to add, but I would say let's go through the case in its entirety first, and then I'll come back to it.
Okay.
And hit the points.
Okay.
So,
so continuing on to the labs are only notable for a hemoglobin of 9.3, so she's anemic. And then a transvaginal ultrasound reveals multiple intramural, meaning that it's inside the wall of the uterus, solid hypoechoic uterine masses. And just for the med students who maybe haven't done much radiology yet, hypoechoic on ultrasound just means that it's like less bright than the surrounding tissue around you. There's isoechoic, where it would be around the same intensity. And then there's hyperechoic, where it's brighter than the surrounding tissue. So it's a hypoechoic mass, and we'll come back to that, why that's important in a second. But so we kind of have a sense here that this is probably, the source of her, both her heavier menses and then her pain as well, as that these masses are contributing to that. So the question is which of the following is the most likely etiology of this patient's pathology? So this is a classic USMLE 2-part question. It assumes that you know what the diagnosis are or have deduced the diagnosis, and then it's asking you kind of a follow-up or a secondary question about that diagnosis.
Yeah. So in that being said, let's go back and kind of parse this out. So, I've always advocated, like approaching each question in a standard format, whatever works for you. Often on the podcast, I forget to do this, but my intention is always to note what the interrogative or lead in or actual question is first, which here is which of the following is the most likely etiology of this patient's pathology. Okay, so basically, in my own words, what is that? What's causing this patient's problem? All right, so that's what I'm going to be like focused on as I then go through the vignette. And now I go back and I'm looking through these sorts of, pertinent positives and negatives like you were drawing attention to before. And in this case, we've got, like your reproductive age woman who's an African American. She's a G1P1, which for you preclinical students means she's been pregnant once and got a baby out of it. She presents to an outpatient clinic for pelvic pain and heavy menses. All right, so in OBGYN land, pelvic pain and abnormal uterine bleeding are some of the most common complaints that we see. So the likely range of answers or list of answers that could be causing this are pretty long with just this information. But we can whittle it down as we continue to go through. Vitals are within normal limits. Okay, cool. So what's that mean? Well, it means if she's anemic, then she's not like decompensated, because if she were significantly anemic, then you're like missing some red blood cells, which means you're missing some oxygen carrying capacity inside your blood, which means your heart rate goes up to kind of ensure that homeostatic delivery of oxygen to your tissues. So physical exam is notable for an enlarged, mobile, non-tender uterus. Okay, so a few things here. It's enlarged. What can cause a large uterus? You should be thinking about this as you go through the vignette. Large uterus, well, you could have a hydatidiform mole, molar pregnancy, which is something that, if, I don't know, you look in like a table in a review book that lists like causes of enlarged uteri. That'll be one of them. But what else? You can have probably more commonly would be or excuse me, less commonly would be like malignant conditions like a leiomyosarcoma, which is a cancerous neoplastic condition of the uterine smooth muscle or the myometrium. Adenomyosis, which is kind of you can kind of think of that as like endometriosis of the uterine muscle. Classically, this was worth remembering because it shows up in vignettes a lot. The exam for somebody with adenomyosis usually is a boggy, like a kind of like a firm but spongy-ish feeling. A boggy uterus would be adenomyosis. All right, let me pimp you. Enlarged uterus in a reproductive age female without any other information. What should you be thinking? There's a couple things definitely, but one thing everybody forgets.
Well, I would say that the initial thing, you want to make sure she's not pregnant.
Boom, pregnancy. Don't forget, like many things in OBGYN, as far as pain complaints and palpable things inside the pelvis, pregnancy can be a cause. It's definitely up there. Whether it's an abnormal pregnancy or a normal pregnancy, doesn't matter. You got to think pregnancy as a diagnosis. But I'm pretty sure the number one cause of an enlarged uterus is uterine leiomyomata or leiomyomas or fibroids. So if her uterus was enlarged, mobile, but tender, I would be thinking adenomyosis, which is kind of just a general enlargement, like I said, like endometriosis of the myometrium, you can think of it like. But this one's enlarged, mobile, and non-tender. Okay. So labs are only notable for a hemoglobin of 9.3. So what else could be said about that? Very often women their bodies will kind of adjust or compensate for chronic anemia. If this were a chronic blood loss anemia, we'd expect to see like a normocytic or microcytic pattern. So you'd look at the mean corpuscular volume, less than 70 is microcytic, or you can have a normocytic anemia with iron deficiency anemia, which is what you get with chronic blood loss. I've even seen, honestly, people with normal vitals and a history of like heavy bleeding, like bleeding for 3 months straight.
Wow.
With like hemoglobins of like 5. And it's like, wait, what? It's like, aren't you dizzy when you stand up? No. Do you ever get palpitations, like your heart's beating too fast or strong? No. Do you have headaches? No. Are you short of breath? And it's just like complete negative review of systems. Like, okay, well, the body's pretty cool, but you can't stay like this forever. So you're gonna need something to treat that. All right, and moving on. So she's mildly to moderately anemic. Transvaginal ultrasound shows those intramural or inside the wall, because I believe it's muris is the Latin for wall. Solid hypoechoic uterine masses, which is a very typical description for uterine fibroids. So to return, after all that long-winded thinking out loud, which of the following is the most likely etiology of this patient's pathology? Well, here are your answer choices. First up is A, endometrial epithelium, B, myometrial smooth muscle, C, uterine serosa, or D, trophoblastic tissue? All right. So, how do you approach these when you're kind of, you know, in the heat of the moment on an actual exam?
Yeah, I think it's you got to think about the underlying pathology, and you got to think about like exactly, this is really getting at what the cell line is. So you want to, so sometimes it can be in the name, like adenocarcinoma is obviously going to be like an epithelial thing. And so you just have to think about, just kind of know your underlying pathogenesis and where these tumors come from. The other thing you can think about is kind of looking, I always try to look for answer choices right away that might be easy to eliminate. I'm kind of a crosser out. I like to cross things out as much as possible. So I think like we were talking is, like uterine serosa, there's not too many pathology. In your explanation you were giving of all the different causes, I didn't hear too much mention of uterine serosa. So that would make me kind of a little less suspicious of that. Plus, like on a transvaginal ultrasound, it's going to be a little hard to see something that's, protruding out from the uterine serosa. That'd be something more you'd see maybe on a CT scan or something like that. Trophoblastic tissue, that makes me think, maybe she was recently pregnant, or, it's something that would have been a result of a pregnancy, and there's no mention of her being pregnant or recently pregnant. I mean, obviously she has a previous pregnancy at some point, but I feel like the question has to be, usually on the USMLE, they have to be pretty direct with that kind of stuff. It's less hazy like real life is. So I don't see too much mention. So these two right off the bat, I think it kind of comes down to these. I mean, you think inside the wall, so you could think, again, it's kind of hard to discern whether it's endometrial versus myometrial if you're kind of going off that. So again, it gets a little bit down to kind of if you know it or you don't in some instances, I think. But I feel like 50-50 is not, it's better than 25% when you originally started with.
Yeah, absolutely. I think what's helpful, so a few things about me. One, I'm a slow test taker. I almost always take the full amount of time for a test. Like
Me too.
my first couple shelf exams, actually first 3, I think I had to like guess on the last like 10 to 15 just because I ran out of time. Also, they only give you a 5-minute warning at that point, which I thought was really dumb because it should be a 1 minute, but whatever. So there's that. But also there's this psychological kind of, I don't know, cognitive difficulty where, if this vignetted set of transvaginal ultrasound reveals multiple myometrial solid uterine masses, which of the following is the most likely etiology of this patient's pathology, I would have been like, oh, I can't pick B, which was the answer, myometrial smooth muscle, because they mentioned that there's a finding in the myometrium. So it's obviously not going to be that because they're trying to trick me. So they're not. That's important to remember. They are not trying to trick you. So what I found was really helpful, and still do, is I'm like about to like start studying for yet another exam, this time for addiction, is as you go through vignettes, like anything that reflexively jumps out to you as whatever, like there's no real basis for saying this, but my own experience, and that's that your mind is probably working, in the background, as it were. We just can't open up our task manager and see like to what degree our programs are still processing, except the one that's, the window in front of us, our conscious mind. But, like if I'm reading through this, I'm like, oh, okay. Pelvic pain and heavy menses, African-American female. I know that those findings are definitely fibroids. And then I keep going through and it's like enlarged, mobile, non-tender. Okay, that's sounding a lot like, leiomyoma, another word for fibroids. Anemia definitely goes with fibroids because they can cause heavy menstrual bleeding. And then this ultimate intramural solid hypoechoic uterine mass is kind of a dead ringer from a diagnostic radiology standpoint. So if I had not looked at the answer choices, which I highly recommend not looking at them until you can have some sort of answer to the prompt. If you don't, that's okay. But if you can come to the answer choices with a decision rather than having your decision on which answer to pick influenced by what you read, I bet you do better. I bet you have less moments that you're like, oh, I know they're trying to trick me, or now I'm going to like get worked up and spend 5 minutes on this one question. You know, these are kind of psychological things you need to work on and get practice with and teach yourself, so that you don't get down to 50-50 with every single question because you don't have the confidence which you ought to have, if that makes sense.
No, I 100% agree with you. I try to do the same thing and answer the question in my own mind before I get to the choices, like you said, like similar to yourself. Because then, like I said, I like to cross answer choices off, and I think if you already have the answer in your mind, that makes that process a lot easier, as well.
It's definitely reasonable, you know, to be like, okay, I think this is fibroid. And then you look at these answer choices and myometrial smooth muscle, you know, like a monoclonal proliferation, a benign monoclonal proliferation of uterine smooth muscle cells equals a fibroid. So really, this is just a term synonymous with fibroid. So I'm zeroing in on that. I mean, it's probably not a bad idea to glance at the other answer choices just to make sure that you didn't miss something. But if you have got to the end of a vignette like this and you're like, I'm looking for fibroids, I'm looking for leiomyoma, and you see this myometrial smooth muscle as the answer, boom, just select it, move on.
Yeah. I think we'll take a minute here going off that. If we'll before we go through the answer choices and just kind of talk, we talked about fibroids or a leiomyoma. And so just to kind of review briefly, like Patrick was mentioning, this is a benign. Usually fibroids almost always are benign, but I think as I say down here, you can have a malignant transformation into a leiomyosarcoma, but that is rare. But the pathology, like we said,
and I would let me interject there. I would say that the dogma has always been that here's the thing: if you can imagine it happening in the body, it probably can happen. Like honestly, like some of the things like I've seen or heard about that are pathologies. It's like, what? So first up, it's a truism. If it can happen in your mind, it can probably happen in real life. But for the purposes of a medical student or somebody just at like a basic medical education level, like even up through step 3, I would say fibroids are benign. They don't turn into cancer. Mm-hmm. And I think that's pretty reliable. But, if somebody has a bunch of weight loss and their uterus grew, 3 times the size within like a month, and you see a finding from the radiologist that says multiple intramural hypoechoic lesions are evidence, like I wouldn't completely ignore the fact that she's got some cancer symptoms. So just throwing that out there.
For sure. No, thank you. And then the presentation, we certainly covered that, but as Patrick can attest, sometimes these are even asymptomatic. And even as a radiologist, we see these all the time, like just incidentally on people's CT scans, like abdominal pelvis CTs.
I believe it's 70% of women have at least one.
Oh, really? It's that high? Okay.
Yeah,
I mean, I guess that doesn't surprise me. I mean, we see these all the time, like when we read abdomen pelvis CTs, especially, and they're just incidentals, heavy vaginal bleeding and or pelvic pain. So they can have one or the other or both, like our patient does. The exam is, Patrick explained very well earlier, enlarged, can be asymmetric, non-tender. You can have palpable masses, but again, you're always going to just eventually get the ultrasound to kind of confirm that. Again, like I was saying, race can be important. It's common in African American women, and the age range is kind of, very young women to kind of up to middle age. But that being said, as Patrick can attest, this can happen in, people of all ages. Again, if you can if you can think it happens, or if you can conceive it, it probably can happen. So you can see women, much older than this, and I imagine even younger than this happening. Another thing that's important is it's estrogen sensitive. So you can have the size increase during pregnancy. It can also decrease after menopause. So again, just corresponding. And then this is just a nice image, those for you watching the video, it just kind of shows the position of the fibroids within, the intramural, portion of the uterus, with, kind of giving you kind of that visual sense of how it arises from the smooth muscle of the myometrium. And you can, and also I think what this image shows well is often women can have more than one, and you can see them in all different types of locations. And as I think we'll talk about at the end here, I'm curious to talk with Patrick about kind of the treatment aspect of this at the end here. But, these can get very large and make these symptoms even much, much worse, which kind of require either the OB-GYN or even in our case, the interventional radiologist to intervene. So I think that we can get back to that in a second. Let's just finish out this question here. So coming back to this, we'll go through the answer choices again. So, endometrial epithelium, endometrial carcinoma or adenomyosis, as Patrick was talking about, can arise from the epithelium itself. Also, the thing about cancer, especially endometrial carcinoma, is it's usually, again, anything's possible, but it's, common things being common, it's usually more common in older women, over the age of 55. The answer, like we said.
And I would even say more simply just postmenopausal.
Oh, yeah.
The average age is 51 for menopause, but just an associated thing to remember as a principle for every specialty is postmenopausal bleeding is always endometrial cancer until proven otherwise. It's not usually endometrial cancer. It's usually actually like a loss of estrogen and atrophy of the, robust tissue health, either vaginally or endometrially, but like a loss of estrogen. But at the same time, it's important enough, and that's the usual presentation for endometrial cancer or endometrial precancer or hyperplasia, is postmenopausal bleeding. So remember that's definitely going to show up on your exams over the years.
Yeah, no, I can attest to that. And it's recently doing step 3, it was on there. So like we said, the answer is myometrial smooth muscle, because like I showed on the previous slide, it's a neoplasm that arises from the myometrial smooth muscle. And then uterine serosa, like we said, not too many masses that typically originate from there. You can have peritoneal carcinomatosis, which is basically like kind of sprinkling of malignant tissue throughout the peritoneum, which obviously comes in contact with the uterus. And then it can be a number of things like ovarian cancer, and then also obviously can be other cancers as well from within the abdominal or pelvic cavities. Then you have trophoblastic tissue, kind of like what I was alluding to earlier. This should trigger in your mind a choriocarcinoma, which arises from trophoblasts during or after pregnancy. These ones, you're going to see beta HCG is elevated in these patients typically. And so again, like we were saying, that this would be if they said the patient was pregnant or had just been pregnant, and then their beta HCG was still through the roof, that could have maybe tipped you off towards that answer there.
Yeah. Trying to think what other pearls. Fibroids, at least, you should know it is the most common tumor in females. That's probably worth remembering.
Sure.
The thing about size increase with pregnancy and size decrease with menopause, that's just a general rule. So don't be too fussed if you're on an OBGYN rotation and real life doesn't seem to match that. It's not always the case, or not simply the case, that because then people will get confused, like, wait, they have heavy bleeding and there's fibroids, and you gave them estrogen, progesterone in the form of oral contraceptive pills. Like, isn't that going to increase the size of the fibroid? And the answer is no, it usually doesn't, but it's not as simple physiologically or pathophysiologically as size increases with estrogen. It just tends to be that way.
I think management could be interesting to talk about, which is a little bit maybe beyond step one, but I think
Yeah.
definitely there's different from your end. There's different surgical procedures that can be done for this, and then there's a pretty slick endovascular procedure from our end that can be done for this as well. Hysterectomy, obviously the most invasive, and then there's the myomectomy, which from what I understand is done, especially if you're trying to preserve fertility. Is that right, Patrick?
Yes. Yep. That would be the go-to indication for that. And myomectomy is simply like removal of the fibroid tumor itself. So for first year, second year preclinical students, you can basically treat the symptoms by giving them medications that will help decrease the bleeding, or suggesting some pain meds if they have pain. But if you're at a point where, for instance, it's so large that they're having trouble having bowel movements, I've seen these things like cause hydronephrosis, like cause the kidneys essentially to back up because they're compressing the ureters. People can have difficulty, with sexual function and intercourse, or bladder function, because these mass effects, it's
all the anatomy.
It's all the anatomy. Yeah, it's like you have a uterus, and when it's too large, it touches all these things and can cause the problems related there too. But usually, once you're at that point, like where you're bodily functions, normal functions are affected, then you're moving on to something more invasive. More and more nowadays, I think the go-to thing is probably something in the radiology suite because it's less invasive. You don't just usually cut them out, like, for a couple of reasons. One, they're often multiple. There's many of them. If you have one like big solitary one, that's a better situation to just remove the tumor itself. If you do have you do a myomectomy and remove the fibroid, that will make the uterine wall weaker. And so if somebody gets pregnant after that, you don't really want them to go into labor. This is more like probably third year, fourth year, maybe even more like OB resident. But you don't want them to go into labor. It's sort of the situation like a VBAC, like if you've had multiple C-sections, that uterine wall gets weak and it can open up and burst during labor, which creates an emergency. And you can remove the uterus as a whole, which is probably the more common surgical approach that we take. You can also, there's a lot of different things you can do.
For sure.
But what about you guys? What can you do?
Yeah, so this is a really exciting aspect of interventional radiology, and it's endovascular, minimally invasive, like you said. Endovascular just simply means navigating catheters and wires through the vessels, endo inside, vascular vessel. And it's similar to like a cardiac cath as far as access. You can either go through the femoral artery in the groin, or you can go through the radial artery in the wrist. That's kind of attending dependent, and even institution. Here at Emory, we do actually a fair amount of these through the radial artery.
Really?
Yeah. I think it's some of our many of our attendees were trained at some of the similar places, so I think that has something to do with it. But again, I think it's preference. Radial artery, it's a little cleaner. There's not like the groin. There's more like flora down there and stuff like that, and it's just also like patient comfort as well. So yeah, so we typically do them through radial artery here, maybe different at your institution. But then we navigate using fluoroscopy, or basically kind of real-time X-rays, if you will, and contrast dye, and kind of do an angiogram to navigate the blood vessels for the fibroid. It's pretty wild, like when you see these things, that you see the complex vasculature of these fibroids, and then basically we thread a catheter through the vessel through that when we've kind of located the feeder vessel, the vessel mainly supplying one of these fibroids, and then deploy different essentially beads that kind of block off the vessel. It's called an embolization. So you basically block off, kind of clot off that blood vessel, and just essentially kill the blood supply to the fibroid. And the thought is that, as a result of that, it kind of dies down and quits, acting up and giving the patient the issues that it's causing, whether that's mass compression or heavy pain or bleeding. And the results have been pretty good. The patient satisfaction is pretty high with these procedures, and thankfully it's pretty minimally invasive, and usually it's an outpatient procedure. It can be done in the IR suite. The patient goes home the same day usually, and it can be done with moderate sedation. Even you don't necessarily even need anesthesia. So we're happy to help these patients in interventional radiology.
Yeah. So, so you can do a uterine artery embolization for this too, right?
Yeah. That's typically,
that was the older approach.
Yeah. And then as we've gotten a little bit better with just our imaging and techniques, we can navigate down to some of those more finer vessels that supply these things.
Yeah. That used to blow my mind though. Like, how can you embolize the uterus and it not die? So that would vex me. It doesn't have to vex you. There's, a lot of collateral circulation, but in the case where you do a uterine artery embolization rather than a specific uterine fibroid embolization, the idea is that the blood flow, I guess, is significantly lessened, and the fibroid itself doesn't take as much blood supply as the uterus as a whole. So those collaterals end up, diverting to the organ itself rather than the fibroid or something of that nature.
Yeah.
But yes, you can embolize the uterine artery, and the uterus will still survive. Probably shouldn't get pregnant, and there's some other things, but it is possible. Just throwing that out there.
Yeah. And we're doing the same thing in males now too for BPH, like benign prostatic, so prostate artery.
Really?
Yeah, that's the kind of the new hot thing in males. Is kind of taking this exact, because this was done first.
Principle.
Yeah, taking these
Yes,
exactly.
that makes sense.
Yeah.
Interesting.
Yeah.
And that, the prostate surgery is fraught with a lot more morbidity, right? Like, I think I can't remember some of the statistics, but
like erectile dysfunction and things like that.
I think ED was like a relatively large portion. I'm not gonna say what, because I don't exactly remember, but you disrupt that nerve plexus, and then stuff just doesn't communicate to down there. But you don't see that so much, do you know, with
prostate artery? No, it's definitely, I mean, I think it theoretically can happen, but I think it's much less than, like you said, if you're surgically removing it. So there's this big push, and we in IR we kind of face the problem of letting people know that we actually, we have solutions for some of these issues that in many cases can be, good solutions, or even potentially less invasive and less complicated solutions as well.
Yeah, that's awesome. Something to think about. It's one of those questions that you probably kind of covered at the DaVinci Hour show as well, because if I'm wanting to go into OBGYN and become like an expert fibroid surgeon, and then the IR people are developing non or less invasive, like minimally invasive or more minimally invasive, because we can also do minimally invasive surgery, but very minimally invasive procedures to treat some GYN conditions, that will have an impact on the availability of those surgeries. And that's a good thing, because, the less you do to a patient to solve their problem, the least invasive to the most invasive is always should be the principle. But cool.
Definitely.
I'm interested in that prostate thing now. Definitely. As I get older, I know that like 100% of us will eventually, if we live long enough, develop some BPH or even prostate cancer. So at least I don't have to go through a transurethral resection of the prostate when I'm however old that happens to people.
Yeah.
We got anything else here?
No, I think that's it. We covered the full gamut, I think, on this one for uterine fibroids, which is pretty cool. I enjoyed that.
Yeah, me too. I'm glad I learned something here too. That's awesome. Thank you.
Yeah.
All right. So coming soon, we'll be doing probably some more terse. What's the plan? We're doing gonna aim for 60 pathology cases.
Yeah, I think something like that. Yeah. The final numbers being determined, but yeah, a sizable portion that will be useful for people for sure.
Yeah. So go check out DaVinci Academy.com.
Mm-hmm.
Right.
Yes.
And see what DaVinci Academy is doing. We'll be back with more next time to help you learn on the go. Thanks for listening as always. And, if you have a chance, go review Max's podcast, DaVinci Hour, because it's always helpful for shows to get reviews. And I will do that too, actually. I have not yet. So
thank you, Patrick.
Do it.
I will do the same for you. And I'll add that for your listeners, we'll give it a nice discount code as well if they want to. If they are inclined to buy one of our products, they can use the discount code ITB20 and get a 20% discount off of anything we offer. So feel free to use that.
Well, thank you. We do appreciate it. So, all right. I'll talk to you later.
Awesome. Thank you. Thank you for watching this video from this new collaboration between DaVinci Academy and InsideTheBoards. Again, to listen to the audio, you can go to the InsideTheBoards platform or wherever you listen to podcasts. Again, to see that all the DaVinci Academy and InsideTheBoards have to offer, be sure to click the links in the description below. Thank you again for watching.